Hi everyone. So today we are going to talk about Brainstem auditory evoked potential, monitoring of the auditory signal or cranial nerve 8, which is the vestibulocochlear nerve during brain surgeries. So what we are going to do is we are going to talk about anatomy and physiology, the electrophysiology, the waveform, morphology, pathologies, they affect our signals, different type of surgical procedure. We can use the auditory evoked potential and data interpretation. So auditory evoked potential are also used in clinical setting for diagnostics purpose for hearing loss, but we are not going to focus that. We are just focusing on the intraoperative application. So looking at the anatomy of the ear, anatomy is the key factor because we have to have an idea or 3D image in the mind when we are stimulating and recording what structures are at risk and what can go wrong. So ear is divided into three major parts: external ear, middle ear, and inner ear. The external ear is start from the pinna or auricle, and then we have external auditory meatus, which is the opening or canal, and then we have canal, external auditory canal, and tympanic membrane. So anything from tympanic membrane to the auricle is known as external ear. The function of the external ear is to collect the sound and transmit to the external auditory canal toward the tympanic membrane. The middle ear starts from the tympanic membrane and until the eardrum. So the middle ear is the air-filled cavity behind the tympanic membrane, and it includes a chain of 3 ear bones. They are very, very small bones, and they are known as malleus, incus, and stapes. Malleus is also known as hammer, which is attached to the tympanic membrane, and then incus is the second one, also known as anvil, which attaches the malleus to the stapes, the third bone, and stapes is also known as stirrup, which is tied to the oval windows. So that the place between the tympanic membrane to the oval window is known as middle ear. We have eustachian tube. Eustachian tube is connected with the nasopharynx. So that's why one of the reasons is that anyone who has sore throat or like a nasal or nasooral infection, it travels up the eustachian tube and causes middle ear infection, otitis media. So if you want to do Valsalva maneuver, if you close your nose and blow air, that pops up the ear, and that's because of that eustachian tube. So the anatomy of the middle ear, when the sound vibrations strike the tympanic membrane, so we have sound energy. So all the sound waves, they travel as a sound energy, and they hit the tympanic membrane. Once they hit the tympanic membrane, it changed from sound energy to mechanical energy of movement of malleus, incus, and stapes. So, and then those move the oval window. And the oval window is attached to the cochlea, the start of the inner ear, and it changes the cochlear mechanical energy into electrical energy. So this results in transfer of sound from air to the fluid medium in the inner ear. So inner ear has vestibular organ, cochlea, organ of Corti. The organ of Corti has basilar membrane, inner and outer hair cells, and tectorial membrane. So inner ear is the most important part where we have to focus now, because that's the place where all the sound waves are created. So right now we are looking at the inner ear diagram. So anything outside to the tympanic membrane is in green is your external ear. The red one is middle ear, which is malleus, incus, and stapes, and then the purple one in this picture is the cochlea and semicircular canal. So cochlear nerve originates from the cochlea, and vestibular nerve originates from the vestibular, and they both combine, they form the 8th cranial nerve known as vestibulocochlear nerve or 8th cranial nerve. The vestibular nerve is responsible for balance, and cochlear nerve is responsible for hearing. So the function of the inner ear is 2 functions. One is hearing and one is equilibrium and body balance. The hearing is due to cochlea, and the cochlea have 3 components: scala vestibuli, scala tympani, and scala media. Equilibrium is due to labyrinth or vestibular apparatus, which has 3 semicircular canals and a vestibule. So when we are looking for inner ear, the bony The labyrinth, the circular canals, the outside is bony and inside in the membranes. So the bony labyrinth is surrounding the membranous part, and there's a fluid between the membrane and the bone and inside the membrane. And these form the vestibular complex, semicircular canals, cochlea, and distal part of the auditory nerve. So the membranous limb receptor with the fluid tubes and chambers and contain fluid called endolymph. And perilymph is a CS-like fluid between bony and membranous. So inside the membranes we have endolymph, and between the membranous and bony we have perilymph. Peri means surround. So here we can see the cochlea and the semicircular canals. So the blue one is in real life there's no blue, but just for depiction, so the blue one is the bony part and the orange one is the membranous part. And yes, called 3 semicircular canal. They are semicircular in a different shape, and the perilymph is between the orange membranous part and the bony part. So that's a fluid circulating there, and inside the orange one, the membranous part, is your endolymph. So there are two membranes in the cochlea. The oval window is connected to the stapes and reduce sound vibration to the cochlea, and the round window, which is act as a way for fluid motion to dissipate and not to be constant motion from all sound vibration induced. So the oval window is moving, causing that movement, and then movement of the basilar membrane and the inner hair cell. When these waves reach the oval window, it causes movement of the fluid inside the cochlea. So if you look at the cochlea, the movement of the oval window due to mediasynchronous stapes will result in movement of the fluid inside the cochlea, and that result in stimulation of the cochlear hair cells. So inside the cochlea there's a membrane. It's called basilar membrane, and that's triangular or conus with the tip and the base, and it is rotated. On top of it is circulated, and it has hair cells, and when the fluid moves, it moves the hair cells. These hair cells are non-spiking and excite neurons of spiral ganglia. So the base of the hair cells, the neurons start from there. They're connected to that, and when the hair moves, it causes the activation of the neurons at the base of the hair cells and send an electrical signal to the brain. The axon of spiral ganglia, neurons travel to the brain as part of cochlear nerve or cranial nerve 8, and synapse in dorsal and ventral cochlear nuclei in the brainstem. So blood supply, which is responsible, and any change in the blood supply or ischemia to this blood can result in loss of auditory evoked potential. It's vertebro-basilar artery, VBA, anterior inferior cerebellar artery, pica, posterior inferior cerebellar artery, superior cerebellar arteries, and posterior cerebellar arteries. So when we look at the auditory nerve pathways, so we have two pathways, cochlear nerve and vestibular nerve, and the cochlear nerve originate from cochlea and join the vestibular nerve to form the vestibular cochlear nerve. So we have the nerve originate from cochlea, go to cochlear nucleus, then it go to superior olive, and then inferior cochlea, and then medial genicular body, and then the auditory cortex. So here we can see the pathway with the waveform. So there are 7 waveform, wave 1, 2, 3, 4, 5, 6, and 7. So they are labeled according to their 1, 2, 3, 4. And they are almost 1 millisecond apart. So wave 1 is about 1.1 millisecond, wave 2, 2 millisecond, 3 millisecond, 4, 5, and 6, and 7 millisecond. So wave 1 is originating from dorsal, from most distal part of the auditory nerve. When the nerve enters the CSF and internal acoustic meatus, so we have external acoustic meatus and internal acoustic meatus, which is the opening of the canal inside near the brainstem, where the nerve enters that. So that's click sound due to change in medium, called wave 2. And then wave 3 is created by superior auditory complex, and then there's a crossover to the other side where we can see to the inferior colliculus, and then from inferior colliculus we have medial genicular body and auditory cortex. So this is the blood, this is the base of the brainstem, and we can see 2 vertebral arteries. They combine, they form the basilar artery, and the basilar artery gives off anterior inferior cerebellar artery, ICA, and ICA gives us labyrinthine artery and cochlear artery, which goes to labyrinthine and cochlear area. So any ischemia to ICA or cochlear artery will result in loss of waveform all the way from cochlea to the brainstem, because if the cochlea is ischemic, everything is gone. So brainstem auditory evoked potential were first described in humans by Jewett and Wilson in 1971. There's short latency far field evoked potential produced in response to an auditory stimuli, which is typically click or sound stimulation. These can be used to estimate the monitor of the cochlea, the cranial nerve 8, brainstem auditory pathway as an hearing sensitivity. So because the signal are produced in all these, so we can do that. So we have peak 1, 2, 3, 4, 5, and 6. So peak 1 is the postsynapic distal cochlear nerve. Wave 2 is proximal nerve, or maybe cochlear overlap from the cochlear nucleus. Wave 3 is superior auditory complex in the pons. Wave 4 is crossover ascending lateral lemniscus pathway in the pons. Wave 5 inferior colliculus in the midbrain, which is right in the fourth ventricle. And then we have medial geniculate body in the thalamus, and then thalamocortical auditory radiation to the auditory cortex. What we are trying to see is we record all 5 waveforms. Wave 6 and 7 are typically not seen in patient under anesthesia, but wave 1 to 5 are recorded. We are recording from all the waveform. The obligate peaks which must be recorded are wave 1, wave 3, and wave 5. So we should always record wave 1, 3, and 5. The largest peak is wave 5, and then we also record the inter-peak latency, which is the latency of the peaks between 1 and 3, 3 and 5, and 1 to 5. So the anatomy of generators of the waves are very important. That's why I'm presenting it again and again. So making sure that we can draw that and remember that is wave 1, the most distal portion. Wave 2 is a proximal portion and some cochlear nucleus. And then there's a wave 3, 4, and 5, so which are coming from the lateral lemniscus, inferior colliculus, and thalamocortical radiation. So why we do that? So we can benefit in different type of surgery. For example, CPA tumors, acoustic neuroma, vestibular schwannoma, microvascular decompression of the facial nerve for heavy facial spasm, even microvascular decompression of the trigeminal nerve. There's a risk of retracting the brainstem too much, and so you don't have to damage the auditory nerves to have a hearing loss. So if it's too much retraction during the surgical procedure, that may result in just the pulling of the nerve or stretching the nerve or overheating the nerve may result in the loss of hearing loss post-operatively. Endolymphatic sac decompression. So patients who have Meniere's disease, sometimes they go under decompression of the endolymphatic sac. So auditory nerve stimulation or facial nerve mounting is important for that. Brainstem meningioma or brainstem aneurysm clipping or coiling. So any surgical procedure around the brainstem or the cochlea need to be monitored by auditory evoked potential. So that was the anatomy and generator. So when we are recording the signal, so what are there are 3 major type of signal that we can record. One is electrocochleogram. Then we have brainstem auditory nerve action potential and brainstem auditory response. So the electrocochleogram, the first response is about 2 to 20 microvolts in amplitude. It's a large amplitude response, and it is recorded directly from the tympanic membrane. So we can place the electrode on tympanic membrane. There are different type of electrode that we can place it. Either we can place a needle electrode through the tympanic membrane, which is very invasive and should not be performed on routine basis. On only ENT surgeon or someone who knows how to do that should be done that. The easiest one is placing the cotton wick electrode soaked in saline on tympanic membrane or gold foil electrode. I'm going to show you later. So the components we record from electrocochleogram are cochlear microphonic, summation potential, and compound action potential. Cochlear microphonic or CM is cochlear activation by auditory stimulation. Summation potential or SP is activation by again auditory stimulation, and they're consistent with the presence of cochlear perfusion. So they are consistent with the blood perfusion. Compound action potential is an initial activation of the myelinated segment of the auditory nerve. It is labeled at N1, which is same latency as wave 1, but it's not wave 1. So this is the component from ECOG, electrocochleogram, so it's known as N1. Auditory nerve action potential, they are much larger. They are about 50 microvolt, and they are direct recording from the auditory nerve in the brain stem. So the surgeon can place the electrode right on the auditory nerve, and you can do the auditory stimulation, record that, and it's a huge response. It's a near field response because you're recording right from the nerve the electrode is touching, and the response we see N1, and that N1 has the latency about same as wave 2, which is proximal nerve, but it's not a wave 2. So the latency is wave 2 is known as N1 of auditory nerve compound action potential. The third one is the brainstem auditory evoked potential, or brainstem auditory evoked response, BAR or BAP, or ABR auditory brain response, and those are the smallest response, about 0.5 microvolt maximum, and they recorded by 3 electrodes placed on vertex A1 and A2, and they record wave 1 to wave 7. So those are the smallest response with the far field responses, except for wave 1, which is near field. So the electrode which are placed again A1, A2. A1 is in front of the left tragus, and A2 in the right tragus, and then C in the vertex. And there are 3 channel recording we can do. The left side ipsilateral to CZ, and then contralateral ear to CZ. So A1 to CZ, A2 to CZ, and then A1 to A2 for wave 1 recording. The right side stimulation, you can do ipsilateral A2 to CZ, contralateral A1 to CZ, and then A2 to A1. So when we are recording from contralateral electrode ear, so just make sure you are not recording from the contralateral ear or contralateral nerve. You are still recording the ipsilateral nerve, but with the contralateral electrode. So these are the quick square boxes which create the sound wave, and they are known as receiver. And because they are sending the sound and we are receiving the sound, this is terminology is from the phone, which will be used to have a receiver and a microphone. A receiver was you have to hold on the ear to listen to sound, and microphone we were talking. So that color in 2 colors, red and blue. Red is for right side, blue is left side. So when you stimulate from right, we should be stimulating the red side. Right side, when you stimulate from the blue, we should stimulate on the left side. The foam inserts, they are foam and they have plastic tube. They come in 3 different sizes, 2 colors and 3 sizes. The 2 colors is yellow and beige, and the yellow color have smaller and large side, which are both adults, and beige color are for the pediatric. And they are connected to the red and blue tubes. These red and blue tubes have small connector which is transparent or white, and those are reusable, but the tips are disposable. So you should never throw the tube or the tips which connect the tube. Then we also have gold foil electrodes. So these are special foam inserts which we saw in the previous. So this is the same foam insert in yellow, but they are wrapped in a foil. So these can be connected to the tubes which has special connection as a cable. So the sound leaves and activate the ear or cochlea, but the gold foil is connected to the tympanic membrane. It acts as a recording electrode, and we can record an electrocochleogram by gold foil electrode. So these are very convenient. The tubes again, this is not the only tube. It has tube and the connection, the probe, the electrode, which is connected to the cable connected to the machine. But gold foil tip is disposable, so the sound is used for stimulation and recording from the cochlea. So this is how electrocochleogram look on the screen. So we have some cochleophonic summation potential and N1, the largest component. The cotton wick electrode is ECOG electrode, and the blue tip, which has foil, very thin electrode. It is wrapped in the cotton. So sometimes it comes in gel. So this one comes in gel, so already pre-gel. So when you open then and you place the electrode, if it is the different manufacturer, there's no blue gel, then you have to soak the cotton in the. You ask the anesthesia to give you a saline small bottle. You soak them, because if it is dry, it's going to have a very bad conduction. Where we can see normal, on the left side, we see normal electrocochleogram, and ECOG is interpreted by comparing the height of summation potential to the action potential. So N1 and AP and then summation potential and cochlear microphonic We look at them and we can see the changes. Here on the right side, we see abnormal electrocardiogram. So the summation potential is higher on the right side. These are the electrocardiogram recording from the cochlea. We can see nothing obtained on the right side. And this patient has high frequency hearing loss. So left side has good recording, but right side has no electrocardiogram. This is another electrode which is called Cuva electrode or Cuva electrode, and it is about 2 millimeter in diameter. It's a C shape which clips you can put on the auditory nerve. So you can place the C shape on the nerve and connect to the computer, so we can record direct from the cochlea. We can record directly from auditory nerve. So when you're recording directly from the auditory nerve, this is giving you auditory nerve action potential. The first one, the electrocardiogram, which can be recorded from needle, a gold foil electrode, or cotton mill electrode. The auditory nerve action potential, you can place the gel. Cotton mill electrode, you have to suture to the skin or some place so it doesn't move, or you can place this Cuva electrode which snaps on the nerve. So there are other successful application by different electrode. We can place electrocorticography depth electrode, and you can place on the electrocortic depth electrode on the nerve and then connect that and record directly from that. So here we can see a preoperative T1 weighted MRI, and which shows left-sided 1.8 centimeter CPA tumor, which is going in the internal auditory canal. So extension and consistent with stable of schwannoma. On the postoperative axial MRI, contrast depicting gross total tumor resection. So in A, we can see the tumor on the right, and on the left CPA going into the canal, and the right side is the postoperative. So this is the placement using of the EdTech in depth electrode, which is typically used for electrocardiography for recording EEG, but this is modified and you can place on the cranial nerve 8 and record directly from edge nerve. So there's a metallic part which should be placed touching the nerve and comparing to non. And here we can see compound nerve action potential during vestibular resection and recorded from these electrode. And then in A, we have regular ABR, brainstem responses, 1, 2, 3, 4, 5. And then in the left pair, we can see A1 latency increase from 1 to 5, the latency increase. So wave 5 is about 7 millisecond instead of 1 millisecond. And on the right side, on the 3, the last one, is a compound nerve action potential with depth electrode referred to CZ with amplitude. And so here we can see on the left side in A, we have ABR, and we can see wave 1 and wave 5 more clearly. With the 2, we see depth electrode, and we can see the loss of the signal somewhere in the middle. And the last one is depth electrode with loss of action potential about at the last 5 traces.